all of the students here have been pursuing a certificate or degree program in behavioral health sciences. So far this semester, we have talked about, throw some things out, guys. What have we talked about? Values,
Culture.
Culture. What else?
Touching.
Yeah. Do we touch our clients? Gifting. Okay. What else?
Spiritual bypassing.
Yeah. What else?
Ethics versus not legal.
Absolutely. And when they conflict. Yep. And we've been working in groups doing a project recently in class where everyone's kind of analyzing the ethical code for a certain kind of complicated little case that I put up on the slide. So that's a little background. I'll introduce our panelists next. So we have Monica Torres. So Monica is running a private practice now, 2 private practices. And formerly she worked at Vital Soul for 9 years. Yeah. Something like that. A long time.
Yeah, a long time.
A whole decade, yeah. I have been highlighting your expertise as far as what relates to our class discussion as groups, substance use, and adolescence. Is that correct?
Yes, I don't work typically too much with adolescents, but I did have a lot of experience with adolescents. So, yeah.
And then you worked with court-mandated clients too, right?
Yes, so I also was director over a court order treatment program, which included a lot of domestic violence, DUI programs, anger management. So it was a diversion program for anybody that was involved in the legal system. They would take the educational courses that were required by the court, and then they would in lieu of incarceration.
And then we have Caitie Adams. So Caitie is the manager over at Crisis Preparation Recovery, and she's in charge of the SMI department. So the SMI stands for Serious Mental Illness. It's a legal designation in the state of Arizona, and it allows folks in the community who struggle with working and functioning and regulation and things like that because of their mental health distress. It helps them get more services in the community. And so she runs a department that evaluates folks who are interested in being part of that program to see if they qualify for it and helps them get connected to services. So Caitie also has how many years experience working with children and families before that?
Oh, about a decade.
A decade.
Before I switched to adults.
Okay. Yep.
Hit puberty.
What's that?
Hit puberty.
Yeah. Yep. And did I miss any of your specialties? Okay. All right. And then I forgot. Both are licensed as a LPC, licensed professional counselors. That's their discipline. TJ's discipline is social work, and this is TJ Reed. He runs the Homelessness division in Maricopa County and does a lot of advocacy and policy work. I probably missed over a huge chunk of what you do, so could you fill in?
Sure. We have a bunch of money that then we contract out for homeless services in the community as well.
Awesome. And before that, you worked at Zulari. Could you talk a little bit about that? What did that work entail?
Sure. Yeah, pretty much all the work history that I've had prior has been in some way, shape, or form related to homelessness and poverty. So some of it has worked in like database stuff of like data analysis. Some of it has worked in direct services. And then some of it was just in how to get people connected to the right types of things when it's a pretty complex system.
Thank you. All right. Unfortunately, our 4th panelist, Elodia, was not able to join us today due to illness, but she wants to come to the next panel that we do, whether that's this semester or in the spring. So she was the one that has a practice in Surprise that works mostly with children and families. So I know I had mentioned her too, so I wanted to let you know that. But yeah, I'm so excited to get into everything today. Let's go ahead and get started. All right. So when we were chatting about what questions we wanted to ask, we kind of had some natural collisions come up. So I'm just going to start at the top. We've talked a little bit about what it means to be a counselor or be in the field of behavioral health. A lot of folks in this room do want to become therapists or case managers, work in behavioral health technician positions or behavioral health professional positions later on. And so just in general, I'm going to start with, what would you say is one of the biggest ethical dilemmas a behavioral health professional can face? Anyone can start.
I will start on that.
Okay.
What you guys will face in your futures in behavioral health is constant evaluation of your own personal biases. You guys mentioned that you had talked a lot in this class so far already about values. You're going to work with people who are coming from backgrounds or going through experiences that maybe you don't have a lot of familiarity with or a lot of experience with, situations that might, trigger you or set something off for you based off an experience that you might have. But you have to be willing to be open to challenging your personal biases always.
I'm not sure if this would be one of the biggest ethical dilemmas, but something that I ran into a lot, especially working in, so in, I guess in addition to substance abuse, I also previously worked with individuals that had sexual offenses of some sort. And so to your point, to piggyback off that, there's definitely a lot of moments in that where there's many opportunities to be triggered and have like your own values get in the way of providing the treatment that they need. So that was definitely something I encountered a lot of. And then I think sometimes what came up for me a lot working with adolescents and individuals like struggling with substance abuse was a lot of times DCS or some sort of legal entity was involved in their cases. So there's this positions you find yourself in sometimes where, a conversation may come up and it falls into that gray area of mandated reporting, where like you have just told me something that now puts you in a position where I have to call DCS or I have to report the case manager of this. And sometimes it's challenging because these people are already struggling, and that sometimes they're in situations where all their DCSs almost always help, should always mandate report. So asterisk, but sometimes you understand that like they've already made like an iota of progress, and sometimes that disclosure could damage the relationship or just be difficult to tell them like, I now have to tell your case report that you told me this. Finding a way to do that like thoughtfully so it doesn't damage the therapeutic relationship, and ultimately like following your ethical guidelines and mandated reporting. It's difficult sometimes.
I want to come back to that in just a second.
Yeah, just going off of that, I think the biggest things that I experienced was as I started to develop my own like values and personal ethics, just seeing that in context with wherever I was going to be working. And so your organization may have differing values than what you have, and they may be requesting or have policies related to things that might go counter to your own personal ethics. And so you'll have to kind of come to terms with that of like, what are your lines of like soft lines that you're like, okay, well, I'm willing to do that on a case-by-case basis, or what are the lines that you're like, that's way too important to me, like I can't work at a place that is going to have policies that may contrast to what I'm interested in. And from my side, it's hard because, right, I work for Maricopa County, which is a bunch of elected officials, right, who have a political affiliation. And so some of the things that they may be requesting that I prioritize, I may not want to believe in or really at all consider something that I should be prioritizing. And so my choices at that point, right, are go along exactly as is, advocate for something different, or leave, right? And a lot of the time that what I do in my job is like harm reduction or like mitigation of something that could be worse. So if there's something that they're pushing down that I really vehemently disagree with, rather than saying either I'll quit or do it as is, I'm gonna do it in a way that provides the least amount of harm to the people that this policy would impact. And that's just like a real thing that you have to come to terms with, right? Of like, it's not always just that, oh, what is right or wrong, or what do you believe to be right or wrong, and just do that. You're gonna be put in positions, whether it's with clients that you're working with, whether it's your organization, or whether it's something broader.
We've talked a lot about how there's a lot of gray areas when it comes to ethics and professional decision making, and it's challenging. Do you happen to have any examples of what you were just talking about?
Yeah, sure. So and I'll say too, a lot of like, if you're interested in therapy, right, a lot of you just listen to them and don't listen to me, right? They're the ones who do that stuff. I'm more on like the macro side, but my hope is that for those of you, I initially wanted to be a therapist, pivoted into more policy stuff because I realized that was my interest. And so an example of this though, I think, I'm trying to think what a good one would be, but so we have a board of supervisors who's elected, right? And they'll, just recently they said, we really want you to focus on this particular thing. So it was heat-related activities. And that's good, right? But in the way that they wanted me to do it was sort of a little bit ham-fisted and may actually be damaging to some folks, where it's not as like client-centered as possible, and it's more just like, if they don't receive the service, we just need to arrest them, or we need to like do charges, right? And so for us, it's just, yes, we will do that, we'll take it. And then when we take it, we implement and require a bunch of things that require client-centered care and like a lot of focus on trauma-informed care that allows for people to be treated really humanely and within that. So I use the leverage that I have in the space that I have to do exactly what I'm asked, but do it in a way that can be impactful and appropriate for the clients that we're serving.
And moving towards ethical decision making even within the structure that you have that you've been given.
Yeah.
Thank you. I like that you talked about harm reduction. We didn't have that on our list to ask about specifically, so I added it. But I appreciate that. I'm curious about times that you faced an ethical dilemma in your field or in your work. How did you make those decisions? What did you consider? Jay kind of gave us an example just now. What about for the other two?
Well, I think kind of, I guess, going more into detail of what I just previously mentioned, you know, sometimes in working with individuals, again, that struggle with, you know, substance abuse is the one that comes up most, I guess, right now for me. But it's these situations where, you know, we have, you know, their case managers asking, well, how are they doing? Because I'm deciding if they're going to maintain custody of their children. And you know that they've been doing really well, but had a recent relapse, right? And you can't lie. You can't say like everything's great, right? So it's finding these ways of, you know, having to disclose, again, in a way that are like strength-based and focusing kind of on harm reduction more than just being like, yeah, well, they were doing good, but now they relapsed, and just being thoughtful and like therapeutic in how I deliver those messages so that they understand like all the progress that was made, because that can be also very discouraging for patients too and clients when we say, you know, we deliver things in a way that are only focusing on the progress that's left rather than the progress that they've made. And along the lines of substance abuse, there's a lot of things that come up, homelessness, right? Things that people consider when giving custody. So it's just navigating, I think, those situations where you want to make sure that like children and other parties are safe, but you also want to deliver the information in a way that, you know, is helping the client in treatment. So it can be very not so clear all the way.
Thank you.
So I'll kind of speak to an example of a dual relationship. If you guys are familiar with what that means, that is when you are seeing somebody, and you have the potential to have multiple relationships with them. Either you've known them previously from other work experience, or you know them on a personal level, something that, or you've taught with them, something along those lines. In my example, I used to work at an inpatient hospital here in the Valley, and inpatient hospitals sometimes have what we call frequent flyers, or people who are in the inpatient system pretty frequently. And oftentimes there is overlap between someone who has repeated inpatient hospitalizations as well as an SMI determination. So I remember when I was an evaluator, I had gotten a referral for a patient that I had seen previously while I was working at the inpatient hospital. And I
So could you all speak to how you handle mandated reporting decisions? Like how do you navigate deciding, okay, this is a case that has to be reported, and then how do you talk to the client about that once you decide?
I would say, so something that I focus on a lot and remind my clients of constantly is the fact that I'm a mandated reporter and what I'm obligated to mandate report. So I constantly remind them, because sometimes in the intake when you say it once, it's very easy to forget, and then they tell me a story, and I have to be like, I have to report that right. So it's constantly in reminding them of what that looks like. So in the event that I do have a client share something with me that is clearly something that I have to report, it's conversation of just letting them know, they will have to make report, and just if they have any questions about that process sometimes. But if it's more gray, sometimes when I was supervising for a while, what I would let people know is you can call the hotline and just say like, this is a hypothetical situation, is this reportable? And they will let you know if it's a report that they're going to accept. So sometimes it's always better if you're questioning it to at least make that hypothetical call so that you know either way if it was something that should have been reported or not, rather than sometimes not reporting something that in retrospect should have been reported.
Good, now you can do that today.
Definitely agree. When it comes to duty to warn, so if somebody is saying that they're going to hurt themselves, somebody else demonstrating unsafe behaviors in the community, it's always best to err on the side of caution. You have a gut instinct, right? Like that kind of pit in your stomach, and you have that for a reason. So if you're coming across an experience that's giving you kind of that gut instinct and you think to yourself, I don't know if I'll be able to sleep tonight unless I report this or do my due diligence as far as maintaining safety. Trust that gut instinct, but also remember that you are working with people and you want to still be able to respect their humanness, their autonomy, but also simultaneously acknowledging that they might not have insight or awareness into the things that they're doing that are causing safety concerns.
What does that mean to have insight and awareness into their behaviors?
Insight and awareness means that you can recognize the impact of your thoughts, actions, behaviors on yourself and other community members. And some people may have mental health diagnoses or symptoms that prevent them from being able to have that recognition or awareness.
I think the only thing I would add is, in my experience, one of my first jobs was at a domestic violence shelter as a case manager, and I think it was helpful to kind of demystify or define what services DCS provides, because I think sometimes all you hear about, whether it's CPS, DCS, or whatever, is what media has kind of portrayed it as, of people ripping children away from family members and like having very dramatic moments with very dramatic music. And that does happen, right? People get split from their children, but that's a part of many of the things that they do. And so I've had in that experience, even though it didn't make it better, because it's a hard space to be in with a client no matter what, when you're having engagement with DCS, it's that, hey, they offer support and services too, right? That like throughout this, the goal is not to break you apart from your family. The goal is to support in building up the family. In some cases, due to safety, there needs to be separation, but at least for families, that was somewhat helpful, because I think immediately when somebody heard like, oh, I'm making a report, they'd be like, you're trying to take my kid from me. And so immediately addressing that head on of like, here's what this means, right? And I do feel like that did help a little bit. It wasn't, it didn't resolve everything. They were like, oh, thanks for doing that. But like, it did make it a little bit less hard of a conversation.
Thank you. And the class also had a question about how to continue working with clients once you have made a report. Like, what does that look like? How do you go about repairing that relationship if there's a break?
to try and move forward past a hiccup or a bump in your relationship. You want to have honest, authentic, genuine communication about how the person on the receiving end is experiencing or feeling about the report or the steps that have to be taken, and being able to defend why you did what you did, why you made the call that you made, and also err on the side of, the goal of making a report is to increase safety and support, not to damage.
Yeah, I think to piggyback off that, a lot of the times when there has been conflict following making a report, or even just a really difficult session sometimes, I always let the client know that this is an opportunity to find a healthy way to move through conflict, because a lot of the times in some of the populations I work, especially looking at like anger management, right, healthy conflict resolution or conflict in general was through. So sometimes it's almost using that real life, like in vivo example to say like, okay, you're upset with me. This is why I had to do what I did. I also want to acknowledge how you feel and like find a way to just like in that session, like look towards like reconciling the issue and moving through conflict resolution in real time.
Thank you. What flow as well from what we're talking about here. So I'm thinking back up under being a counselor, speaking of like different barriers that you can encounter when working with your populations. Obviously, if relationships are ruptured individually, that's, where that communication is really important and helpful. But what would you say are some of the biggest barriers that you run into? The question was specifically asked about children and families, working with them, but even just in working with the populations that you specialize in and work with, some of the barriers and how do you work with clients on those?
I think one of the realizations I learned early on was that some of the barriers that clients are facing are a lot of the times not always within the counseling room or things that are easy to solve, right? So a lot of times, we're looking at more of like homelessness, right? We're looking at like unemployment, are sometimes some of the stressors. And I think what's sometimes difficult in working with clients is, they get sent to me for, anger management, they got in a fight with somebody in a store or something, right? But when you really like look at it, it's hard to sometimes like, okay, well, we're gonna learn healthy communication skills in this psycho-ed group, but really they're battling like homelessness and the loss of their, children or grief, and there's like so many environmental factors and other things that are at play. So sometimes some of the biggest barriers in therapy are finding like community resources and ways to alleviate some of those underlying needs before you can even really start. Like I remember distinctly, I'll share something. I was working with an adolescent many years ago, and they were difficult in many ways without getting into it. Just, I guess, kind of standoffish, right? Like not really fully engaged in treatment. And then I learned later that they were like struggling to the point where like they were going without food. So when you think about it, it's like really hard to employ healthy coping skills when you're dysregulated, when you're going without food. And I think those are some of the factors to sometimes consider. It can be challenging because sometimes you can't fix all of it, or any of it sometimes.
I will kind of piggyback off of that and just note one of the big barriers related to mental health is the stigma that's associated with it, right? I mean, in my humble opinion, I think our society has really come a long way as far as normalizing mental health and making sure that it is a priority and not something that is looked poorly upon. But there is still a lot of stigma associated with mental health, mental wellness, mental illness. And I can speak specifically to the SMI or the serious mental illness population. A lot of people that I meet with will tell me right off the bat, I don't want to meet with you, I don't want to talk to you because you're trying to get me committed, right? Or if I have this SMI determination, that means that I will have my rights taken away because that means something about me as a person. Or people will think that it means that their kids are going to get taken away. less rights or access to things that other normal people do, right? So sometimes a person who truly needs care will not seek out care simply because their fear of the stigma that's associated with it. And a big chunk of the work that you guys will do will be trying to normalize the need for mental health care.
And I was just gonna go off of too, I feel like the social work side of it is that I think the CDC has like a good frame of like, they call it like ecological systems, and there's therapeutic like methods like this too, but the idea is you view things like in an ecosystem, that it's not just a person, right? They're within an ecosystem, a lot of other things that impact them, that there are things that they can do personally, just themselves, that they can improve. But it's not just there, right? So in a counseling session, you can work with somebody on beliefs and, you know, like lots of different things, but yeah, it's not gonna provide them, their kids, a meal tonight, right? And so that the way that it's framed is that it's like self, relationships, community, and society, at least in this, there's 1,000 different versions of that, but like with that, it's for us to keep that in mind as we work with each individual client, of being able to understand that it could be any one or all of those things that can support them, of like, hey, what about relationships and building up healthy relationships? What about connection to community-based organizations because you need to get a job or you need housing, right? A big barrier for families is housing. Our rents have gone up like 75% in the last few years. For those who have families, there's restrictions on how many beds you can have for the amount of kids you have for a lot of the programming that we're talking about. So that's a lot of money, and you may be a single parent. And so that's something, right? That if people don't have housing, it doesn't matter. I mean, a good example of this is like if somebody is continually going to the doctor with like, you know, a cough, and they're just giving cough suppressants like every week for the rest of their life, like that doesn't resolve anything. But if you ask the question, it's like, oh, I'm sleeping outside. Oh, well, if we got you indoors or out into your own place, that would resolve a good chunk of the things that you're dealing with there. And so I loved what you were sharing, because I think that is a big part, and I think that's a misnomer sometimes with counseling, that you need to resolve everything in that room with somebody, and you can't. Like, you can support them, but it's a lot of, it's beyond you, right? It's not just you, and it's figuring out what actually are the needs of this client, and then being able to make sure they get to the appropriate thing that is most helpful to them, in addition to you. Not saying you're like not useful, but like you're one piece of a bigger system.
That's an important point, keeping in mind like the impacts of various systems and contextual factors.
I look at that as the seed that I was planted is like, it's your job to be a guide, not a god, right? You can't do all of it. You can put them in touch with things, right? You do your best, but ultimately there are going to be things you can't solve now. And I think that's one of the more challenging things about, you know, recognizing where the work ends, or where you just can't do anymore.
So, like, advocacy is a really great topic to insert in this space here. So, given that there are so many things that impact our clients that we can't directly help them with, or that, you know, we can only refer out to, what is the role of counselors and behavioral health professionals with advocacy? What does that look like? What are different ways that folks can get involved, and when would they want to get involved?
I will kind of speak to the importance of your documentation here, because a lot of times when you're making referrals out for individual or for other services, referrals will need to include any history that you have on your patient, anything that you have done with the person that you're working with. So making sure that you clearly document some of the stressors that they are facing, the symptoms that they're working with, the challenges that are ongoing, being clear and objective, and really advocating, saying why you feel that they would be a good match for the service that you are referring, or why you feel it would benefit them to engage in that service
don't do that, what might that look like?
This will be, if you haven't heard this phrase already, if it's not documented in this field, it did not happen. So if you don't document clearly, or if you are putting your emotion into documentation, really writing a picture of the person's story, that can really follow them in a negative way.
I would say, in terms of like advocating for clients and putting them in touch with resources, I saw that there was a question on here that made me think of this, of like, is there a time it can actually be harmful, right? And I think sometimes it's easy to forget that the goal is for them to not need us anymore. Obviously, there's some cases, right, where people will need longer care, right? But for the most part, we're looking at how do we teach like resiliency, how do we teach them to put themselves in touch with resources eventually, right? So, you know, sometimes it's especially in case management or social work in particular, it's sitting down with the client if there's an application for them to complete and getting the information from them, having them be a part of it so that they can also learn to advocate for themselves one day. Because if we're always doing this background work for them, you know, teaching them, okay, if you do run out of food, how do you get a food box? How do you access these resources, right? So that if something does happen and it's a weekend or someone isn't available, that they actually know these places to go, or they know how to get in touch with these resources themselves too. So we're not creating dependency if it's not needed.
And I feel like there's so many different versions of advocacy in there. Like even using the last example, right? There's advocating to the client on behalf of the client. There's advocating to like other people or organizations. There's advocating like at the legislature for different policies that may impact the populations. But like one that I've experienced on the clients, I'll do two, one on the client side and then one more on the like broader societal side, is like there are some times where you want to advocate on behalf of a client. Like so in our space, some of the clients are connected to mental health clinics and they have a case manager, and their case managers actually have expectations around what they should be doing for the client. And so sometimes when we're advocating on behalf of the client who needs connection to that case manager, we have had to like escalate those things to like a supervisor to say like, hey, you know, we know where this person is, and the person, their case manager, is saying they were trying to check in, but they're clearly not. Like we have them right in front of us right here, and like so it's being professional and respectful, and then clear with your documentation of like, you know, there was supposed to be a meeting at 10. We waited there from 10 to 10:30 and no one showed up. I have that documented, just wanted to let you know, right? So you're not trying to be like, well, this person's an asshole and they didn't like this person. It's just like, hey, I'm just telling you, I know this person has a case manager. They're not getting the services they need. I want to advocate on behalf of my client, right? But on the other side, I think it is really important for all of us, like in this space, to really understand our personal capacities for other advocacy outside of that. One of the reasons why I pivoted from therapy to doing macro stuff is because I was frustrated by some of the policies and procedures in the organizations that I was a part of that I felt like were damaging to people. And so it's like, oh, I want to spend some of my time advocating for these things to be shifted in line with some best practices or research that would be more helpful for people. But that also extends to like society, right? There are policies in place, like in housing, that actually limit folks, right, from getting into a stable place to live. And so I will spend some of my time on that as well. But there's just, you know, there's advocacy across that whole board, and it's really a personal decision of like how you want to prioritize your capacities and time in that space. We're limited folks, we have limited energy, you're not going to be able to do all those things, like, and I think we could probably all tell you that from experience too, and you probably have experienced this as well when you've gone into that space, like, I'm gonna save the world, I'm gonna do all these things, and then you realize that like you're exhausted and burned out, and now you can't help anybody. So it's important for each of us to understand our own capacities.
So we have a question on that, so let's go to that side of things next. Under boundaries and consent, we had kind of talking about like how do you prevent counselor burnout or professional burnout, and what do you do when you realize you're bordering up on that? What are some of the ethical implications there?
Your emotional boundaries, boundaries in general is kind of what you decide you're going to put up with or not going to put up with, right? The limits that you put around your energy and emotion. Burnout can absolutely happen in this field when you are giving your energy and emotion to other people who are going through lots of traumatic and very stressful experiences. A lot of times your boundaries develop just as part of your experience. You know, you learn what you're not willing to put up with and what you don't want to experience again by experiencing that. So always be mindful of, you know, your own personal thermometer, I'm gonna say. You know, recognize when you're kind of getting low on energy and emotion, because it'll come out. You'll be able to see it, or maybe you'll snap on something small that normally wouldn't bother you at all, and that's really gonna be the time that you want to do things that help fill your cup, so to speak, right? Like, whatever it is, if it's listening to really loud music, if it's going hiking, if it's, you know, hanging out with friends, family, traveling, tune into the things that help keep you feeling level, because you can't serve anybody else if you aren't okay.
Yeah, I mean, I think to piggyback off of that, so did you justify me here next to burnout? Because I was like, now it's dawned on me. I was like, oh, I know why I'm here now. So, I worked in community mental health for probably about 8 years, and it started in an intensive outpatient program for substance abuse, and then I became a supervisor, and then I became a director, but it became of all things. So I was like a director of our general mental health, which was like 3 sites across the valley, but then they were like, well, you're alive, so like, let's give you court order treatment. And I was like, I mean, okay, I like that, I could do that. And they're like, you know, also, because you did so well with those 2, we're gonna give you another program. And I was like, I can do it, I'm gonna do it all, right? And it's learning that you, like you framed just like a thermometer. I use mine as like a cell phone battery. And there are no like check engine lights that will actually come on. It will come up in very, very strange ways, right? Come up in your health, it can come up in you just being very short-tempered with everything all the time, right? But it will eventually come up. And I think the difficult thing is, in these fields, and sometimes in organization work especially, there is no time where people just don't need help. So if you're willing to give it, there is a place for you, right? There will never be a day where it's like, actually everyone's doing just fine. No one needs anything, everyone's great, we're all fine. So if you're willing to put in 10 hours, you can. And if you're willing to put in 12, you can. And if you're willing to put in 14, you can, and there will still be more work. So some of the things I had to learn was like, being done is actually not real. It's just not a thing. And also having those boundaries on like, if you're gonna work 9 to 5, whatever your hours are, right? Being very thoughtful of trying to contain it within that, because there will always be another fire to put out, and there will always be somebody else that needs something. And of course there's exceptions. You can't just say there's a crisis like clocking out, right? But when that becomes a habit, the cell phone battery will die. And you know what comes of that is lots of burnout that I can attest to.
Yeah, totally. And just I feel like continuing that string of like it's really being honest and coming to terms and learning yourself, because only you can answer that question. And I do feel like finding your own voice and your own boundaries in this space is not only difficult, it's needed, but on the other side, it's almost like we have a culture that pushes us to not. So like in this space, it's like, oh, do you not care? Do you not care about the people? So you're just gonna, so this impacts pay, right? Because pay can be really shit, and then people just justify it by saying like, well, you're in a helping profession, of course. Like you're not gonna, you know, whatever. It can justify your 8 hours turning to 10, turning to 12, turning to 14. Hey, the need is there. Do you really like care? Do you really want to help? And I think for each of us, we have to get to that space where we understand our own boundaries and have our voice in that, because people will make you feel terrible in this space, and unintentionally. I don't think they're trying to be like, you're selfish and terrible, but that's the way that it can come across. And so for you to be confident in your own space of like, no, I am, well, and obviously it does depend on your role, but like setting your boundaries that like, my work phone goes off at 5. If you need to be on call, be on call or whatever, but it's like having those practical things for yourself because you know yourself. And then the last thing I would say is like understanding those things that fill your cup is a very honest and difficult thing to do. Netflix and chill on one day might actually do that, and on the next day might be completely unhelpful, that you're disengaged and you end up the next day just feeling equally as terrible. And so it's for you to understand for yourself, like, what are the things that you need in the moment. Sometimes it might be a distraction. Sometimes it might be something that's really engaging with a friend. But that again is just only you can define that. Like nobody else can tell you like, oh, go horseback riding or something. Like that might work for them really well, and for you that might be the most painful and annoying experience in the world, right? Like for me.
Yeah. That's fair. Yeah. So what would you all say is the like ethical implication here? Like when you are at that burnout capacity, how can that impact you and others around you? Person in question.
If you are operating from a state of burnout, you're not offering up your best self, right? You're not putting the best version of you into the work. And if you're burned out, you are likely also feeling jaded. So maybe the next person that is sitting in front of you that tells you something that you would have had empathy for a couple of weeks ago, and now you don't have any empathy for that, it's going to skew the recommendations that you make, the treatment that you provide, your body language with the person. You can't tell me that other people don't recognize when your body language says that you're annoyed or tired of them, right? So if you are operating from a state of burnout, it's going to impact the quality of work and service that you provide to the person across from you.
So we kind of mentioned how do you define emotional boundaries, and how do you go about creating them?
I think part of healthy boundaries is, just being able to set the thermometer, right? It's almost like a self-scan and then just saying like, can I take this on right now, right? And that can be in professional life and also in personal life, right? So if you have worked an 8-hour day of doing some level of direct care, and then your friend or sister calls you and they're like, I would like to process my breakup with you for the next 4.5 hours. It's instead of just being like, yeah, sure, yeah, I'm here for you. It's taking that moment to like self-scan and just being like, I can give you 15 minutes, friend, and we have to pick this up tomorrow because I just don't have it in me, right? And I think the hardest part is being able to say no, right? And not say no never, right? Maybe say no never, depends what it is, I guess. Depends what the request is, you guys make to make that decision, right? But ultimately it's being able to say like, I just can't pick this up right now. Can we push this to next week? Or I just don't have the capacity to take on this project right now. Is there any way can revisit this at a later time, right? Rather than taking it on, what's one more thing, right? But one more thing can become 10 if that becomes a pattern, and then I think that's when, I guess just like what I view, I guess just to leave on this note with this topic for me is I see a lot of people that get burnt out and then take like a weekend trip to Sedona and then come back and do the same exact pattern of saying yes over and over and over again. So it's like you didn't cure burnout. You just saw trees and sunshine for 2 days, which is great. That is amazing and you should do that. But it goes right back to that same piling it back on. So part of it, I think part of preventing burnout, if possible, right, is saying no and then, keeping up a pattern where you're self-scanning and knowing when you're at your own capacity.
What about when it comes to like you're meeting with clients who have experienced quite a lot of trauma a lot of times, have gone through some heavy stuff, and they're talking to you about this? I'm mean, most of us in the field, start with a good amount of empathy, like how do you balance not taking it all and carrying it around with you, but still being able to be empathic and being present with your clients.
So I think, just to kind of start with trauma-informed care, right? Because at the most basic level, trauma-informed care is knowing that the people that are coming to counseling have experienced some kind of trauma, and their experience of trauma, no matter how severe that experience was, impacts the way they think, feel, and behave. But after meeting with, your 6th to 8th person of the day who is telling you maybe a very similar story as far as their traumatic experience, we might start to feel kind of jaded about that. And it's important to just always recognize that. We have to have a very clear assessment of our own space, just as much as we do with the person that we're seeing.
Yeah, I would say in order to try to prevent that, what I do is I find like my own system that works, right? Just based on, how I know myself to be. So, staggering clients, right? So I see 3, take an hour break, snack, right? Take a breath, walk outside, right? And then I see 3 more. And sometimes when you're looking at your caseload, sometimes the spaces that they're in and what needs that they have, right? So sometimes I stagger it, or I set my schedule up in a way that's going to allow me to provide this, level. Okay, I'm not going to put my most high-risk people, 9 in a row on like my last day of the week, because I just know it's probably like my cup is a little emptier, right? So I think it's knowing like what works for you, and I think I would say like being strategic, but there is a level of being strategic involved in it to try to help yourself navigate it, because I think burnout will come in the field at some point. It's just learning how to do your best to navigate it.
I think the only thing I would add is just like I like your phrase of like prevention, because in all the issues that we're talking about, there's prevention and there's treatment. And same with this, on this side of things, there's prevention and there's treatment. If all you focus on is the treatment side, you're always going to find yourself back there. But if all you focus on prevention, you may be in burnout right now, and it doesn't matter the plans and strategy. That might feel really overwhelming to try to create a plan and a strategy because you're already burned out with the work that you have to do in the current moment. So figuring out your own balance of that, of being able to plan and prevent, but then also in the moment, what do you do when you're in crisis? It's the same thing with like, one thing that you'll likely do is like safety planning with people, right? And safety plans, there's a couple of different variations of that. It's one is how do you like prevent harm by putting yourself in safe situations, but then you also have your sort of like 911 of like, well, what happens if I am in that space? I have to have a plan to do something there too. So focusing on both of those, I think, can be really helpful in this space.
Absolutely, thank you. All right, so transitioning a little bit, the class had questions about what boundaries do you recommend around self-disclosure plans? I want to acknowledge within this question that, we talked about how depending on the setting and some of the, ways that your life might overlap with clients' lives, like there might be some situations where it's more appropriate and less appropriate, as well as, we talked about how in treatment of substance use, a lot of times there's like a culture of like, a lot of times folks who are in recovery will work with folks who are less in recovery, and there will be a lot of disclosure there. So with that in mind, what are your thoughts?
So I kind of have my own little saying here that self-disclosure is great in vague but purposeful doses, right? So specifically as it pertains to substance abuse, I think that it's very normal and healthy to acknowledge with your client if they're struggling with substance abuse that more than likely, I mean, everyone in this room has probably had some type of experience with alcohol or marijuana, right? So if it's part of our culture, part of our society, let's normalize that so that they don't feel so off-putting or on the spot when they're sharing their experience about it. But you're also going to want to have very clear boundaries, like, oh yeah, you know what, if you're not telling the person, I went to a rager when I was in high school and I really got messed up after that, you know, you don't want to share that type of information. And think in terms of making sure, and I'm gonna kind of loop in countertransference here too, because you don't want what you're sharing or what you're experiencing or what you're receiving from your interaction to cause you to lose perspective of the client's experience and needs.
Yeah, self-disclosure. So, I agree with that. Purposeful and vague. I like that. I'm actually gonna use that word. But absolutely, I think anytime I do self-disclose, it is usually very vague. And I think that the times that are coming up, I guess, to memory where I have self-disclosed, it's a lot of the times to offer somewhat of like a normalizing feeling to what the client's experiencing and to give maybe some sort of like hope for the outcome. And similar to like substance abuse, it's like, yes, like these things do happen to people and, you know, through the work, like, you know, we can move through this, right? But very vague, and then also when anytime I'm gonna self-disclose to a client, I also ask them first to say like, you know, would it be okay if I shared like something with you right now? Because if they're in the middle of like, you know, like really processing what they're going through, and be like, I had that happen too, right? So sometimes it's actually just checking in with them and seeing how receptive they are also to hearing a story if it connects.
That's good.
Love it. Yeah, one thing that I remember hearing a lot was talk about is this potential self-disclosure for me or is it for the client? As kind of like a little thing you can say to yourself too. Because if it's just something that occurred in the moment that's like, oh, I would want to share that, you know, and it's kind of coming up naturally the way it would with a friendship, maybe that's something that's for you. But if you think the client may benefit from something you're sharing, give them hope or normalize an experience or something like that, that might be a good time to consider.
I guess something I want to add that may tie into maybe ethics and boundaries is sometimes the dangers of over-disclosing. So over the years, there's been clinicians that have started disclosing maybe too much information, and that has led to wishy-washy boundaries or feeling like much more of a friendship than a, you know, client-clinician relationship or therapeutic relationship, and that has caused small issues just from, hey, you know, we need to touch base about this, you be more thoughtful of your disclosures, all the way to dual relationships or unethical relationships that result in like loss of licensure, right? So it can, there's a spectrum of it, but it's just kind of being thoughtful of like, to your point of like, who is this disclosure for, what's the intention behind it, and making sure, because it can be slippery. Many clients come in and said, yeah, my last therapist, they just talked about themselves the whole hour, and I'm like, what? What do you mean? And I've heard that way too many times, so just being thoughtful of that.
Since you brought up countertransference, when something the client speaks about, you go with something for us as professionals, how do we handle that?
Recognize it. It's probably going to happen. I mean, as I mentioned before, you're going to work with people from all walks of life, all different experiences, things that would have gone through or done things that maybe you agree with, maybe you don't. Maybe you have a patient that reminds you of best things that you can do for yourself in the process of becoming a counselor is to also get counseling yourself, to address the things that may have happened to you along your lifetime so that you can have a better awareness of what you might be going into your roles with. It'll help you, it'll really help you gain awareness. And some of the best clinicians are good because they've been on the receiving end and they know what it's like to do the work and how difficult it can be to challenge yourself in therapy.
When I worked at the domestic violence shelter, a lot of the folks that I'd worked with had been through domestic violence themselves, and so in working with clients, some would say very similar stories to what they had experienced as well, and it could be really triggering for them. And some were like had done it for a long enough period that they were able to like self-regulate in the moment and work with the clients. But in other times, what was really helpful at that space, and this wasn't a therapeutic setting, this was more like BHT or case manager setting, was we had a really good culture of support at our organization that was just about honesty and like coming to terms with where you were at and what support you needed. That there may be times that you hear something and it slightly puts you off, but you're able to like recenter. But there may be those times that it's like you just get slammed and it's too much, and if you were to try to help, it would not be really supportive, or you might be off. And so those are the moments where it's reaching out to that network of like, dude, this person really needs help. Does anybody have the capacity to support in this space? And in that culture that was created, everybody talked about that being one of the best things, because you knew you weren't alone. You knew that other people would experience similar things to you like that too, and you knew that people had your back, and that it wasn't going to impact negatively. That again, that's a lot more specific to like not in counseling, because you don't always have like a second like therapist to just chime in for you or something. But like when you're in BHT settings, there's usually a lot of staff, and if you have that culture or you want to start to support in creating it, it can be really, really helpful.
It's really great. Sometimes that can happen, I think, in like group therapy settings as well. Like if you have like a co-facilitator or something, you kind of tag team for each other like that. How would you all recommend gaining experience and comfort with the field and some of these positions without causing harm to clients along the way as you're learning?
I encourage everybody to try all different types of jobs in this field. There's so many different opportunities. You can be a case manager at an SMI clinic, which is going to be a different experience than a case manager at a general mental health or GMH clinic. You could be a tech at a all-girls residential treatment facility. You can work at East Valley Men's homelessness shelter. There's so many different opportunities to get you experience and to get you kind of looking at the things that you really like and the things that maybe you aren't so comfortable with or don't feel confident in your abilities. But challenge yourself, try different jobs.
Yeah, I think the idea of becoming more comfortable without doing harm. I mean, if I probably think back to like my first year of counseling, I don't know that, I think at the time I felt like I kind of knew what I was doing, but I'm not sure that I would say that I was like clinical excellence, right? So, but there were certainly some on-the-job learning, right? Because some of the things that come up in these sessions, I certainly did not learn in school, right? Like nobody said like, these are things that are going to be disclosed to you, and this is how you sit with it. Like that level wasn't, it's not found in a textbook usually, right? So I definitely think there were some moments of not quite being sure what to do, and in those cases, I think that a lot of the people I was working with at the time, just to have somebody to listen to was very healing. I think that there's going to be times throughout your career where you reflect and you're like, oh, I wish I knew this intervention 4 years ago, right, with that one client. And that's just part of the growing process, right? I think if we're talking about two separate things, one is being a new counselor and growing, and then one is like doing harm, right? And I think that there will probably be mistakes that are made, and hopefully in those cases there's supervisors that you can also go to and check in with, that you can take hard cases to and say like, I am stuck and I don't know what to do here, and I don't feel like we're making progress, right? In that case, the supervisor can help you go through it, troubleshoot, find interventions, refer out, right? But I think part of it too is not going in thinking that you're going to be a perfect counselor and always make the right things. I still don't always say the right things. Sometimes I've left sessions and I've been like, what happened there, right? And it's just learning from it and then doing it different next time.
Yeah, I feel like one thing that was really helpful for me, because when I finished grad school and really wanted to get into homelessness, I kind of didn't really know where to start, and I didn't really, so at like the latter part of my grad program, I just started to like identify places that were involved in this space, and started to call and say, is there anybody that I could chat with about this? And like I ended up doing just like grabbing coffee with a handful of folks in the field that I had just worked through to say like, what is the day-to-day like what is this like? That not only helped me understand the field, but it helped me understand what I was getting myself into in terms of a job, because they would say like what they're spending their time on. And you could like volunteer and find community meetings and all sorts of stuff around the topic of choice that you have. And that's sort of like the prep side, but I love what y'all were sharing too, because there's only so much prep you can do. And yeah, to be frankly, you will do some harm, like everybody else. And like, obviously you don't want to go in just guns blazing like, well, I'm gonna like destroy everything, but like, you're gonna make mistakes, and that's fine. Like, it's about you being self-critical enough to learn from those things. And that's why they're entry-level jobs. Like, you being in this class and having some of this education will be much further along than a lot of other people who are starting in this space, right? And so this is an amazing start for you all. And then you will have people in each where you're able to learn more training and learn more from experience. And the more time you put into it, the more and more that you're going to come to terms with the things that are working and that you rely on. But I think to the points made here, like, even when you're in this field, if you stay in this field for 20 years, you're still going to make mistakes, and you might accidentally do something that causes harm to a client in their situation. It just hopefully becomes less and less the longer that you're in this space.
We have about 7 minutes left, so I want to open it up to everyone in the class for follow-up questions.